Good morning, good afternoon, good evening, wherever you are. Welcome to Virtual Grand Rounds. It's a special presentation this week. It's the last presentation for the year. We've had certainly an amazing year, and I thought I would highlight some of the important clinical trials that were presented this year and what it means to our clinical practice. All this premier education is brought to you thanks to our sponsors, AstraZeneca, Medtronic, and also Medela, the Science of Care. So I'm going to start with a review of clinical trials from this year, and here are some of my disclosures before I start. Now, perhaps the most controversial results for this year has to be the JCOG 0802. It's a topic that has been discussed many times over the last few months in multiple internet forums, and I thought I would just summarize some of the background to this. If you recall, about 3 years ago in 2022, the Japanese JCOG 0802, apologies, let me share my screen. Thank you for there we go. So some of you may recall in 2022, the results of JCOG 0802 were presented and published in The Lancet. And the authors concluded that segmentectomy improved overall survival by 3.2%. It's interesting because they didn't really clearly report other outcomes in the abstract very clearly. That recurrence rates, of course, were higher, twice higher at an absolute value of 5%. And there was no difference in recurrence-free survival, and especially no difference in lung function lost. In fact, the lung function results, very interestingly, were not even presented in the main paper, and you had to look at the supplementary report to even understand or know or read about it, that in fact there was no lung function loss. Despite that, the results for JCOG 0802 were extremely contingent on lung function parameters, and we'll go and talk a little bit about this in a minute. Of course, then this happened in May in Seattle. The JCOG 0802 investigators went on stage to present the 10-year follow-up results, and shock and horror suggested or reported that there was no significant differences between the two groups anymore. What's really interesting is that many people think that the effect went away or disappeared, and the answer is no, it didn't. The effect got larger. The overall survival improved by 3.8% compared to earlier 3.2% with the previous report. The difference is that the authors had to soften the wording down to say that there was no difference in, or the results favored segmentectomy, when actually it became statistically non-significant. And if you look at the confidence interval, the actual hazard ratio crossed the line of no effect, but suggesting the 95% confidence interval also includes the possibility of an 11% worse survival. Obviously, that's not going to be the case, but this is what happens when you have an initially well-powered study of over 1,000 participants. And then when you on follow-up, and if you have done any work on data sets this large, you'll understand that everything is significant. At 1,000 level, at 10,000 level, which I've worked with data sets that big, every single thing is significant, because that's how p-values are derived. P-values are derived as a function of sample size. And so as the sample size increases, p-value gets smaller and smaller. And to guard against, and that is considered a type 1 error. And to guard against this, we need to declare what clinically meaningful difference is, because 1%, 2%, all will become clinically, statistically significant. And rather than me and you deciding what's clinically significant, probably the most fair way is to use what the authors have defined in their own trial protocol. They declared the non-inferiority margin as 5% and an improvement of 3% in a massive sample size, given that every single p-value will be significant. implies that this is a type 1 error. So I just want to explain it to you because when we or when I mentioned this on LinkedIn, there was a lot of misunderstanding about what is a type 1 error. Why can't you define a type 1 error? How do you know it's a type 1 error? And that's principally what it is. If you look at the two graphs on the left, you have the 5-year survival plot in 2022 reported by the authors. And here you see the 10-year survival plot really showing no difference. So my take on this is that for the first time, JCOG 0802 and CALGB 140503 are now aligned. So in summary, there's no difference in overall disease-free survival compared to lobectomy and with sublobar resection. You get 5% absolute higher recurrence rate for sublobar resection in both studies. This number was relatively consistent. And no difference in lung function loss and no difference in overall or disease-free survival. That's just factual. That's the maths, and we should interpret it at face value. The issues is that both studies quantified lung function loss. Neither study quantified lung function preserved. So what we end up is a group average of how much lung is lost rather than how much you can actually preserve if you do a wedge of a lingula compared to a left upper lobectomy. And it's common sense that the wedge will be about 5%, upper lobe is 25. You're going to save 20% at an absolute risk of 5% increase. I think we should use absolutes because if you're going to use relatives, twofold increase, you need to explain to yourselves and your patients what the actual control value is. So if it's around 5% for JCOG 0802, the recurrence rate will be about 10% higher with the sublobar resection. Given that not many patients will be comfortable in multiplying in their head, so on and so forth, absolute values, I think, is much clearer. One of the main issues with both JCOG 0802 and CALGB is that the whole world's perception of segment and lobe is a bit weird. It's not that clear. In fact, it's arbitrary because the right upper lobe is the same as the left upper division segment. The right middle lobe is the same as the left lingular segment. So in these anatomical areas, you're not going to find any difference in segment versus lobe because it's actually the same amount of lung tissue as well. And of course, many other people also rightly point out that the lesions never sit nicely in one single segment. So you do a segmentectomy, you end up doing 3 segments, 2 segments, which ends up being functionally equivalent to a lobe. Now, the bottom line is that when you talk to patients, in my view, is that you should discuss the actual specified potential anatomic saving for lung function, because you can calculate it in your head very easily, and let them balance it against the 5% increase in absolute value for a recurrence rate, given no difference in overall or disease-free survival. That's a simple explanation. It's consistent in both trials, and I believe it's the correct interpretation and view going forward. Now I want to move on from that total bombshell to something I find much more interesting. I cannot possibly summarize all the trials relevant to our practice this year, but one of the main areas which I think is a potential to increase is our possibility of surgery in advanced lung cancer as part of multimodality local consolidation. And to give a bit of background to this is really interesting because I don't know how many surgeons are aware, but every single guideline to date already recommends surgery for oligometastatic non-small cell lung cancer. So here's an ASTRO guideline, American and European guideline, radiation guidelines, recommending RT and or surgery. It's great. You've obviously got the STS guidelines written by the wonderful Mara Antonov, who also recommends or summarize evidence supporting surgery for oligometastatic lung cancer. And then here's the most interesting thing. Even the medical oncologists in Europe are saying that highly selected patients may be considered for lung resection with therapeutic intent in stage 4 disease. Now, this article was written for non-oncogene addicted metastatic non-small cell lung cancer. And a little bit more of the background, a big blow to this is the NRG LU002 study. That was last year. The paper hasn't been published yet, as far as I'm aware, but the results were announced by Dr. Punith Iyengar, who was also here for the virtual grand rounds. And these are patients who do not have EGFR or ALK mutations going in for immunotherapy, followed by surgery and radiotherapy or radiotherapy with an attempt to improve disease-free survival. Now, the NRG LU002 study sadly reported no difference in overall survival. So despite ESMO recommendations for surgery in non-oncogene addicted, this study in non-oncogene addicted shows that surgery and or radiotherapy actually doesn't have any effect in terms of overall survival. There is, however, a different take for oncogene addicted disease, which I think has very different results. So here is the results of North Star presented by the MD Anderson group, and this was presented at ESMO earlier this year. Patients with locally advanced or metastatic non-small cell lung cancer. And what's pretty amazing about the MD Anderson group is that they included patients with polymetastatic disease. Firstly, there is no standard definition of oligometastatic, 3, 5, pick a number, right? And for polymetastatic, personal communication with John Haymack, really, really a forefront thinker in this, suggests that it's not the number of mets, it's the biology of disease. So when you have EGFR positive disease, which responds phenomenally well to EGFR TKIs, you can expect, even if you have 100 lesions, back down to a few minimum or no lesions in some cases. So they randomized patients initially to receive osimertinib, followed by randomization to osimertinib and local consolidation, which includes surgery and radiotherapy, or osimertinib alone. And of course, there are another two mind-blowingly important concepts introduced in this study is that they also allowed for patients or tracked patients who had full local consolidation, all sites treated, versus partial local consolidation, where not all sites are treated. Again, very, very forward in their thinking. And the results are mind-blowing. I mean, it's incredible. So they demonstrated so far a 34% improvement to progression-free survival. And they also reported out the improvements in survival depending on the number of metastases. If you're less than 3, the hazard ratio was 0.67, and you have more than 3, the hazard ratio was 0.7. Very similar, again, proving John Haymack's hypothesis that it's not the number of nodules. So doctors, oncologists, surgeons getting so worked up about the number of nodules. I mean, this is suggestive of evidence of that the concept of biology is much more important than the number of nodules that you see, which is completely arbitrary. In fact, even if you have polymetastatic disease, complete local consolidation treatment gave you phenomenally longer progression-free survival. Incredible. Now, these results were actually consistent with Chen, who reported at the World Conference of Lung Cancer, a very similar study design where patients with EGFR positive disease were randomized to TKI plus local consolidation or TKI alone. And again, they showed a phenomenal hazard ratio of 0.48. This is still early stage data. The final data won't be out yet, but the two estimates are broadly consistent. And so for this topic, with regards to local consolidation in advanced lung cancer, early studies from Gomez et al. Suggested a 54% reduction in the risk of death with surgery or radiotherapy as part of local consolidation. Iyengar reported NRG LU002, suggesting no benefit of local consolidation at all. But with EGFR mutant lung cancer, Gomez and others in the initial papers suggested up to 85% reduction in the risk of death. In North Star, it's more modest with a 34% improvement in progression-free survival. And with Chen, it's about 52%. And maybe it might settle down closer to the, between 30 to 50 range as they do with clinical trials. The effects normally are highest or best when the early results are out. And then as the data mature, it kind of, difficult to maintain such high levels of efficacy. There is, of course, the Ramon study, which I led in the UK, which didn't manage to accrue. And fortunately, we have the Salvage study, which is run by Isabel Opitz in Switzerland. I think it's a European multi-center trial. The Salvage study is very similar to the Ramon design, where all comers will be randomized. All comers means whether you do or don't have oncogene-addicted lung cancer will be randomized to local consolidation or no local consolidation. And given these screen of results, we can predict roughly that I think it's unlikely to reverse the results of Iyengar. So if you have surgery and or radiotherapy, likely no effect. And probably this will be mirrored in the oncogene addicted cohort. Now, the problem is with our advanced disease cohort, the minority are oncogene addicted. So if Salvage completes the study, I suspect the majority will be non-oncogene addicted, and therefore will dilute any potential beneficial effect of surgery in the advanced disease setting. The Salvage study is powered on quality of life, which is interesting because quality of life, in my opinion, is expected to be worse with local consolidation therapy, but I think they've got a good number, and overall and disease-free survival or progression-free survival will be, I think, important secondary endpoints, which perhaps may be considered primary endpoints for what it's worth. Ultimately and finally, we're all not going to be able to get anywhere unless we have a good grounding in statistics. And those of you who are interested, I'll leave this slide up if you're interested to learn more about statistics so that you're able to interpret the studies and be able to discuss and understand the evidence in more depth. So I want to thank you all very much. You've been a fantastic audience this year. And of course, to thank our sponsors, it couldn't have been done without them, which is AstraZeneca, Medtronic, and Medela, the Science of Care. They've been supporting us for many, many years now, and certainly feel very grateful to them. I'll open today's talk for discussions, so please post any questions you have in the chat, or anything which you would like to ask about the first two topics which I've presented today. The new series for next year is going to be phenomenal. It's going to be fantastic. And we are going to put the speakers up for next year's lineup very shortly on the website. We will start again next year on the 16th of January due to the New Year break, so on and so forth. And I hope to see you then. We've got some questions here from the audience. Anonymous attendees asking, first-line EGFR TKIs have changed systemic treatments. So we need new studies. And that's definitely true. And I think that that's definitely an important subset of patients for which we are going to have much more involvement in. The other subset, of course, is the ALK positive subset. And the ALK positive subset also has phenomenal results. In fact, the entire oncogene addicted subset eventually, and maybe in the future, we'll be thinking about basket trials like what they are doing in the US to ascertain if initial treatment with a TKI reducing the polymetastatic to a reasonable oligometastatic setting, we'd be able to offer more treatment improvements with surgery. Having said that, North Star suggests that surgery as local consolidation, even for polymetastatic disease, is going to be important. Another question from another anonymous attendee. In regards to local consolidation treatment, if the patient has minimal response to systemic treatment, would you offer surgery? The short answer is yes. Would you offer local consolidation treatment? So the local consolidation treatment paradigm is based on absence of progression or stable disease. So if you have stable disease, you would be in the qualifying criteria for local consolidation. If you have minimal response, that's even better. You have stable disease and a little bit of response. Question from Dr. Therese, who's asking about evolution in mutations in the genome with progression in stage 4 disease. Would it influence local consolidation treatment? It's a great question. The short answer is we don't know, but what we do have is the option that surgery allows you to identify the progression of clonal evolution. So if you have initial TKI treatment and you resect the residual disease, you're able to resequence the tissue and determine whether or not progression has occurred. A good question by Dr. Obadale, who's asking about RFA or microwave ablation. Are there any studies looking at these outcomes? And the short answer is no. No randomized trials as far as we are aware. The Ramon study in the UK allowed radio frequency ablation or microwave ablation, percutaneous ablation techniques as part of the trial design. Sadly, we didn't complete the study, but I think that for the local consolidation treatments, you've got surgery, radiotherapy, and ablation. Um, they aren't competitive. It should be complementary. We have only a limited amount of radiation that we are allowed to give patients. So surgery or ablation, especially in areas which are hard or high risk for radiotherapy adjacent to the heart, such areas, which can maybe easily be treated with surgery, and or very peripheral lesions or small lesions not being able to be treated by surgery, treated very well by local ablation, so on and so forth. So that pretty much summarizes the questions for today. Once again, thank you for being such an amazing audience. We've got a great lineup for next year, including some very interesting announcements we're going to make as well. So I hope to see you all on the 16th of January, where we were going to restart the studies. One or two final questions. One from Dr. Addy, who's been asking this many times and got an answer. Any update on the Violet trial? And shortly, you might be seeing a very big paper coming up soon, looking at overall survival in an individual patient data meta-analysis, combining the results of Violet with that of Pleece in Copenhagen and with that of Long Hao's paper in China, looking at overall survival. We presented the initial results of the World Conference this year, showing VATS improved overall survival by 20%. So that's going to be hopefully an important update to be published for next year. Best wishes for the holidays, and I hope to see you next year. And once again, thank you very much for your support. Bye-bye, everybody. Have a good day.